262 in the ADT alone group. And the treatment failure events in the combination group was 248 versus 535 in the ADT alone group. So significantly higher rates of overall and failure-free survival than ADT alone.
You know, as a scientist, I had to question, because there's no control here. You know, did these people also get docetaxel? Did they get, radium? Did they get, those other things?
They basically said they had ADT alone or ADT plus abiraterone acetate and prednisolone was the combination therapy.
Yeah, abiraterone was given with prednisone, but like I'm saying, that these people
Steve,
that in the control group
Steve,
that died, were they given other forms of treatment?
Steve, I think you can safely assume, because I'm not intimately familiar, but the quality of the Stampede study is pretty good. So I think you can fairly well assume that the people in the control group were only getting ADT. I mean, this isn't a cowboy study. I mean, I think we can.
They do say that it says local radiotherapy was mandated for patients with node-negative non-metastatic disease and encouraged for those with positive nodes. And they basically treated them until they had progression, or they had, radiological, clinical, or PSA progression.
I mean, I'll definitely.
Otherwise, treatment went.
I'll definitely take a look at the study in the next few days. But what I'm trying to get at is, Dennis is concerned. Well, maybe the chemo wasn't the right way. I mean, what we know about chemo is that it definitely extends overall survival. And my question is, well, did this study look at what was the end point of the study? What was it trying to measure? It sounds like it was measuring time to failure rather than overall survival. If it was measuring time to failure, then I don't think we can be considering whether it's better or worse than doing the chemo yet. We need to know, we've got to compare apples to apples, and comparing time to failure to overall survival is not comparing apples to apples. I mean, is that fair comment?
Well, they did address that, Rick. It both extended time to failure and overall survival. And I think it was at a 30-month period. The difference was so great between abiraterone and placebo plus ADT that they allowed the placebo track to switch over to abiraterone.
Okay, but how much, by how much? I come back to my original question. By how much did it extend overall survival? Do we know that?
Well, I think someone read it as 71%, didn't it? I forget who it was. Christine, maybe? I don't know who was speaking.
Yeah, but that's not in terms of months. 71%.
40 months.
Okay.
40 months was the median follow-up, it says. And in that time, and these were one-to-one, the randomization apparently.
Okay.
And in that time, there were 184 deaths in the combination group and 262 in the ADT alone group. And as far as I can see, there was nothing in here at all about chemo or any comparison to chemo.
Yeah, there was nothing that did not compare to docetaxel, and it was and they're saying, the thing that I'm reading saying, that's the next step is to try that, but it's going to be a lot more complex. And the 71% was time to failure.
Yeah.
Okay. Well, I'll do my best to try and take a look at it before the next meeting, and anybody else, and we can sort of try and resolve this and at least get a better direction as to what this study actually said.
Sure, I think that's a good. I think it's a good idea because there's been a lot of emphasis and talk about early chemo, but maybe this changes the game a little bit. But, yeah, let's study up on it and talk about it a week from tomorrow.
Yeah, I think that's the key point is if abiraterone can be used up front prior to cascade resistance instead of going right to Taxotere, the side effects are clearly less, and that would be a great benefit if that's what they're proposing. As I said, that what I read on this, just the abstract, it was only 30 months, and so they hadn't achieved the significance in overall survival. They just had some numbers, 180 versus 217 or whatever. So I think it's, the reason I'm saying this is probably a poster board is because it's really not baked enough for long enough to really say what the conclusions are. New England Journal is that's a primo medical journal. They're not going to publish something that's bogus. But I think the intent of the authors was we need to study this further.
Okay.
Okay, Dennis.
Sent you the link to the New England Journal of Medicine article.
Good. Dennis, thanks for bringing this up. We're going to move on a little bit, okay?
Sure.
Susan Johnson, you've got an update.
Yes, I do. Last time I was on was about a month ago, I guess, and we were just about to go and have the conversations with the medical oncologist and radiation oncologist for those who weren't there, because he's got biochemical recurrence of the prostate cancer. So we had those meetings, and we met actually with two of the medical oncologists, Dr. Chi and his the person who was with him, the other doctor, the fellow I think he's called, Dr. Kalaf, and they both basically said radiation therapy is proven to delay progression in some cases, and about half of patients will benefit from radiation. There is a PSMA PET scan clinical trial that he could join once his PSA was up a bit more to 0.4, and that that would be in order to be able to determine where the cancer has spread to. The alternative to radiation would be to keep watching and initiate hormone therapies when the PSA is higher. We had asked the question about the quality of the radiation treatments in the hinterlands, so to speak, and we were advised that the radiation treatments are managed provincially, not by each center, and that they're moving towards 100% quality check. So he basically said he'd have the radiation done in Abbotsford if it were him. So that was the one day, and then we were kind of like, okay, well, obviously everybody's going to say that he should be having radiation, so maybe he should be having radiation. And then we met with the radiation oncologist the next day and got a little bit different message, which was that because he's had a drop in PSA, it's kind of confusing things. Doesn't feel that there's a rush to get the radiation. The lymph nodes were clear, but there was one cancerous prostatic lymph node, so it had does mean that the cancer has escaped the prostate, and talked about quite a bit about radiation treatment and the side effects, and mentioned about the 10% of patients who have long-term side effects, in which case they don't actually manifest from sometimes up to 2, 3, 4 years after the treatment, and in some percentage of those they're severe enough to cause a lot of bleeding and need need additional treatment, colonoscopy, laser treatment, etc. They don't have any way to predict who's going to have side effects. That's kind of that's the lottery part of it. 50-50 chance that you'll have a good result, and 10% chance that even with the cancer control, it will still have long-term side effects. Anyway, he didn't think it was particularly urgent to start hormones prior to the autumn. Basically wait until the autumn to start the hormones, and then 1 to 3 months on hormones before the radiation starts. He sent him for another PSA test, which he had, which has come back at 0.20 again. So now we've had 3 results basically dropped from the reading down up in December. And so not as much urgency. There'll be another PSA test in mid-July and one in early September, and then we'll, in the meantime, do a CT scan and a bone density scan as a control so that they can rule out any pre-existing conditions. So we are actively researching options and trying to get more information about what kind of radiation treatments do they actually do in Canada and BC for prostate cancer? Is it IMRT or not? And also screening options. I mentioned there's a clinical trial, but it's not yet recruiting for PSMA PET scanning. And then something that, is it Peter Kaska that's on this call?
Yeah.
I'm wrong. Anyway, someone mentioned in the Inspire forum that UK has better options for scanning perhaps than we have in Canada, or compared to wherever. And I wondered whether, Rick, you had any insights on that, on the UK scanning situation, because we happen to actually be British citizens in addition to Canadian, so we could theoretically go to the UK, and if the scanning was able to detect the cancer at even at a 0.8, it seems still that to us that blind radiation is not really making a lot of sense. So that's the update.
Well, I mean, essentially, it's good.
Rick can speak to this. I just make a quick comment. I was responding to a guy, I think from Ontario, who was having great difficulties getting any kind of medical cooperation over there in the Toronto area, I believe.
Mm-hmm.
I wasn't suggesting there was better options in the UK, but I was just suggesting maybe in the UK he'd be able to access health care that he couldn't access in Canada, for financial reasons particularly.
Well, there is some concern that Canada is behind other countries. Partly, to be fair, it's a smaller population over a wider area. But, if there's treatment options, well, not so much treatment options, but the scanning options that would be at least able to allow you to make a decision with something more targeted than just radiation to the entire prostate bed.
Rick could probably speak to that, I'm sure.
I mean,
If he's still awake.
yeah, this is true. Couple of things. First of all, I'm not aware of what sort of PSMA scanning they're doing here. I have a meeting with Prostate Cancer UK tomorrow, and whilst I'm up there, I'll see if I can find out. I've got a meeting with the CEO, but I'll see after I'm done with her whether I can speak to some of the people that have greater technical knowledge than I expect she does, and see what's here. The big problem in the UK, from what I can gather, is accessing these trials, because it all depends on who's treating you, and it's not clear to me how you get referred to a teaching hospital, which is where you need to be. I mean, I had dinner last week with the founder of PCUK, who is a genitourinary medical oncologist at the Hammersmith. I know that you can get to see him, but that's privately. I don't know how you would get in to see him through the National Health Service. And I can ask tomorrow and see if I can find a little more about that. That's the first thing. The second thing is, are they doing any PSMA screening trials in the UK? I honestly don't know. I don't even know where they list their trials. A lot of their trials are listed on clinicaltrials.gov. But for example, all of the Stampede trials, I don't know where you find the listing for them in the UK. What I would say is that there are trials being done with PSMA screening in the US. I know that the UCSF for sure is doing it, and I know a couple of people that it's been offered to. But I don't know how accessible those trials are for Canadian citizens, if at all. I mean, those are my thoughts on the screening. My thoughts on pelvic girdle radiation, I guess, are that if it were me, I wouldn't be too concerned about over radiating. I mean, that's my own personal opinion, probably because that's the treatment that I got. What I think, if you're a Gleason 8 and your disease has come back, and remind me, did Grant had surgery originally, didn't he?
He was in a clinical trial in 2012, which we got into through basically researching and trying to find other options. That clinical trial involved 6 months of docetaxel and Lupron prior to the surgery.
Right.
And by the time they did the pathology report after the surgery, they said they couldn't determine the Gleason because of the treatments.
Right.
So it had been 8, but it's been 5 years, and the doubling rate is almost 2 years. So it's no longer behaving aggressively.
Right. So here's the point. If you feel that his disease is worsening or recurring, which it may be, then at some point the disease has to be treated in a more than just a local manner. So even if you knew exactly where the cancer was, you'd want to radiate the whole of I would want to radiate the whole of my pelvic girdle, because sometimes the cancer just cannot be seen. And if it's raised its head again, I'd want to nail it and do whatever it took to nail it right now. That's how I would approach it. I wouldn't be too concerned about finding exactly where it is and then trying to shotgun each spot where it's seen, because there are going to be places where it can't be seen, maybe even with the PSMA screening. I don't know. I mean, in theory, I suppose the PSMA screening should pick up every prostate cancer cell every prostate cell in the whole body, or every cell that exhibits PSMA antigen. But it may not. So, you have to look at the downside of not screening, of not doing pelvic girdle radiation, which is that you might not catch it, and then it spreads, and then you get into a situation where you're always chasing, you're always behind the 8 ball, and you're always chasing the disease. So if you have a chance right now to go for durable remission, and that chance is to do pelvic girdle radiation, maybe a few months, 4-month therapy and pelvic girdle radiation. If it were me, that's what I would do. Ask some of the other guys. I mean, this is a subject you will wrestle with. What would you say to Susan? Len?
That's what I did. It worked for me. It's still working.
Yeah.
But that's my situation. I had IMRT 11 months after surgery when my PSA started rising, and now I'm off of everything, and hopefully I'll get a durable remission out of this. But I did not have a scan after surgery.
Len?
You had IMRT.
Yes, I had IMRT in San Francisco. 39 days ago.
Len?
Does anyone have any?
Hold on a minute, Susan, before we go. Hold your question for a second. Len, why don't you talk about your situation? Because you waited a long time.
I did, yes. My oncologist was scaring the hell out of me, telling me I should not have radiation because at some point 15 years prior, I had IBS, irritable bowel syndrome, which was cured 15 years ago, but he still felt that was high risk for IMRT. But anyway, after waiting, I don't know, 2.5 years of being just on ADT, I'm Gleason 9, by the way. Rick and our good buddy, rest in peace, Dominic, convinced me that I should have the radiation, and I did have it. I finished it last September, and I wasn't maybe quite as successful as Peter. My PSA did not go to undetectable, but it did go down to 0.1. And I'm glad I did it. Oh, I'm sorry. I should say I had IMRT to the full pelvic girdle, along with the prostate.
Did you also have the surgery as well?
No
as
surgery.
Peter?
No.
No surgery. Okay. My
Correct.
dad also had 40 IMRTs with no surgery.
Okay. I had 48 sessions. I don't know.
Oh,
Maybe
okay.
yours were a little more concentrated, or your dad's.
Okay.
But these situations are not
Things.
like and like. These situations are not apples and apples, Christine, because your dad had, when your dad was diagnosed, correct me if I'm wrong, but I don't think they thought the disease was metastatic. They thought that he had disease and they thought they could treat him. And they could, I hate to use the word, but they thought they could cure him. And then the disease came back.
He was not he was not metastasized until 4 years later.
Right. And with Len, in Len's situation, Len was suspected to have more advanced disease at the time that he was diagnosed. And so it's not unusual to have
Yes.
a lot of radiation up front, like what I did, for example. And then the disease comes back, which is what we're talking about in this particular case, where Grant's disease has come back. And now, does he now follow up with radiation? He's never had any radiation. Should he follow up with radiation? And that's the normal course of treatment. The question is, when do you, usually most people wrestle with not whether they should do the radiation, but when they should do the radiation. And I think in my mind, I would do it earlier rather than later. There have been studies that show that the earlier the intervention, the better it is. So I think that speaks well to it. I don't think it makes sense to hang about. And I certainly don't think it's a concern in this instance as to damage from the radiation, because the alternative is far worse. You know, I have a very weak bowel, and and most of it is from the radiation. But it's sure better than the alternative. I can work around it. I can live with it. It is what it is. You know, I might not be here today if I hadn't done what I did up front. So I'm all for treating a disease aggressively enough to give you the longest length of survival you can with, you know, somewhat compromising your quality of life, but not too serious. Susan, you've been trying to get in. What was on your mind?
Well, I would be interested if anyone in this group has had a prostatectomy and then is looking at salvage radiation to the prostate bed, not having a prostate there at this point.
Well, that's what Peter did. That's exactly what Peter did. And who else has had follow-up radiation after?
That's what I had too, Rick.
Tom Price.
And I did too.
And Bill Franklin.
Bill Franklin.
Yeah.
So this is after a prostatectomy you had it?
Yes.
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 And in terms of side effects, I've been, some of the things I've read was that salvage radiation, part of the issue is that you don't have anything there to kind of absorb the radiation, and it would otherwise, basically it goes in directly to the rectum and the urethra, etc.
The only, I think the only side, this is Don Price, very few side effects. I don't, I have to go more frequently. I have to urinate more frequently, and possibly that may be due to some of the radiation that the bladder took. But it's not, it's minor in the big scheme of things.
And how long ago?
What?
How long ago did you have the radiation? Sorry.
Oh, this was around, say, December 2014.
Okay. The other thing I've been trying to kind of understand is how targeted they actually do in Canada. We're not everyone, they're not all using IMRT. I know that. And the question is whether IMRT would in fact be the treatment that they would use, or whether it would just be less targeted, I guess is the word. So,
Susan, I'd recommend that you visit places, some of the institutions, find out how new their machines are, find out how much prostate work they do. Just kind of ask around the different facilities and get a feel for who's doing what and who's got experience. You might be surprised. Hopefully, you'll be surprised and have some good feelings about things. That's what I did. That was my journey. I wanted to find the best I could find. So I actually planted myself 2,500 miles away from home, and spent 3 months doing this. Even though it was awkward and uncomfortable, I made the best of it and had a good time. Went to a lot of movies and plays and museums, but I chose to go someplace rather than home because I felt I'd get better service.
did your insurance cover that, the fact that you were going somewhere else besides where you were based?
Yes, but I've got very good insurance and they covered it. They didn't even flinch or ask.
Any idea what the cost was?
I'm guessing it was probably around 200,000. I don't know how much insurance paid, but I'm sure 40 days of radiation is pretty substantial.
I mean, I can tell you that
we won't.
I can tell you that when I did the radiation, the bills that I got were $300,000 or $400,000 from UCSF. What was actually paid by Kaiser at the time, Steve could probably tell you, but I guess it probably wasn't much more than $30,000 or $40,000, because what's charged to an individual is very different to what's charged to an insurance company, is very different to what's charged to somebody who has a contract with the institution. The bigger issue for you is what's available in Canada, because I'm not sure it makes a lot of sense in talking to people about what their insurance covers or not when they're in the UK, or when they're in the, for you maybe in the UK because you can get it through National Health Service. Although I just heard yesterday that, or tonight I think it was, that they want you to be resident 6 months now before they give you access to the National Health Service this week. But having said
that doesn't surprise me.
You should be looking at Canada, and you should not be looking at any equipment that is more ancient than providing IMRT, because that's been the standard of care now for more than 10 years. And equipment that doesn't do that is really out of date. It doesn't really matter how focused it is, because that's not the issue for you. The issue for you is the skill of the radiologist. It's in making sure that you do all you can to protect sensitive areas. There are these gels that are now available that some hospitals use and others do not, that you could insist on that protect the rectum. That wasn't available for me when I had my treatment. But you know, a concern I have, Susan, is that you, and that you're not alone in this. You get onto the forums like Inspire, and you read a lot about all of the troubles that people experience. And you read about radiation being focused. Well, that may be the right thing and the right concern for the people that are writing, but when you're doing pelvic girdle radiation, you want to spread you want to be sure that the radiation is well spread over the entire pelvic girdle. You don't want it focused.
Mm.
And so sometimes you'll be concerning yourself over something that isn't appropriate in your own case. I think in this case, what you want to be sure is that you get state-of-the-art equipment and you get a radiologist who really knows what he's doing. And is it possible that Grant will have some issues going forward with incontinence, either urinary or fecal incontinence? Yeah, it is, because that's what happens when you have radiation down there. And, you know, it's a fair amount of radiation. At the same time, many people don't have those issues. And a lot of it's the luck of the draw and how you respond. So, I mean, I would say that if you go to UBC, the chances are they're going to have very good equipment. If you go to the local radiologist down the street, probably not. So, you know, try and go to the best institutions that are available.
Mm-hmm. Yeah, I've got my task list of things to check, and as I said, the radiologist is expecting that we'll come back in September, and that would be the earliest that he would start hormones.
What equipment
at that point?
What equipment does he use, this radiologist?
Well, and here is my failure to sort of ask that explicit question when we were in talking to him, probably because I confronted with someone who is obviously authoritative. I listened to the side effect stuff, but I did not ask specifically about IMRT or shielding.
12 calls at 11 at 10 o'clock.
Sorry, say again?
I think somebody was...
Sorry, I didn't hear the comment.
No, I think somebody might... Was that a comment for us, or was it talking to somebody offline? It might have been just some background noise. Somebody hadn't muted themselves. Well, I think start there. Just call them. Find out what equipment they use. That's the best starting.
Yep.
And ask him if he uses the gel. What's the name of the gel, guys? I always forget. Anybody?
I think you have to have a prostate before they can use the gel, because it goes in between the prostate and the rectum.
Okay.
That's what they told me. It's Space-Or,
right?
Yes, I remember seeing. Yeah, no, you'd need to have a prostate for that to work.
Okay.
Anyway, these techs are very good at what they do if they have experience with prostate work, and I wouldn't sweat it. You just you might have some side effects, but after 6-9 months they kind of disappear and you're okay. I mean, radiation doesn't discriminate between the good guys and the bad guys, so you're going to have some upset stomach and that. It comes with the territory, but you get past it and you'll be okay. So anyway, we have to move on. So Susan, keep in touch. Don't let a month go by. Let us know what your findings are and how we might be able to help you. We'll all keep our ears out for other stories.
Thanks.
Okay, Len, you're up. I think Eric had to leave, so Len, you're up now.
Peter, I didn't have anything.
Oh, okay. I crossed you out. Okay, Paul Frieda.
Paul, are you still with us?
Paul, still with us?
Paul's issue was...
Okay, sorry. There, now I'm back. Go ahead, Rick.
Yeah, I was just saying, Paul's issue was when the ADT stops working, does it then make sense to get castrated, to get an orchiectomy? And I don't know, Steve, do you want to take a shot at explaining that?
Yeah, sure. There's virtually no benefit of doing an orchiectomy once the either agonist or antagonist, the drugs you're taking, like Lupron, basically, if they're suppressing testosterone and you're getting a rise in testosterone or DHT, it's probably from adrenal origin, not from the testicles per se. And so I don't think anybody, if a doctor recommends doing an orchiectomy, the only reason they would do it is if you're having so many side effects from the Lupron, you know, that you can't take it. And that would be the only reason to do an orchiectomy these days. If somebody's saying you need to have an orchiectomy because the Lupron is not working, I would get another opinion.
Well, when the Lupron's not working, what does it mean? Does it mean PSA is going up, or does it mean testosterone's going up, or does it mean they're both going up?
Well, Lupron not working means your testosterone is going up. Okay, presumably the only situation where that would happen is if you're not absorbing it for some reason. And sometimes on the every 3-month dosages of Lupron, for example, towards the tail end of the 3 months, it kind of wears out. It looks, if you've had Lupron 3-month injection, it looks kind of like mayonnaise. I mean, it's this thick stuff. And it's called a repository injection because it takes a long time to get absorbed. Sometimes towards the end of the 3 months, you know, it stops getting absorbed and your pituitary gland kicks in and it stimulates your testicles to produce more testosterone. Usually what you do at that point is just go to monthly Lupron or Firmagon or something other than the 3-month dosages. But assuming that the Lupron is otherwise working, and do you have a rising testosterone or dihydrotestosterone, or what makes you think it's not working?
What brought it about is that I was like a week late for my treatment, my 3-month treatment, and my testosterone came in at 29, whereas previously it's always been below 10 or around 2 or something. So I started thinking about what's going to happen when the Lupron shots don't hold back the testosterone. And then it occurred to me, it seemed the most perfectly logical thing would be to get castrated, and then there won't be any more testosterone, and then the cancer won't have any food. And even though I understand there's another gland that can produce some testosterone, at least you would drastically reduce it. So it makes logical sense, but there's something I'm missing, apparently, because everybody seems to be pretty firm that you shouldn't do it.
Well, the Lupron will not stop working. I mean, you may, at 3-month intervals, you may find that it's not working as well at the tail end of the 3 months, but it generally takes, you know, at least 6 months for that whole pituitary testicular axis to kind of come back and start developing testosterone from your testes. The adrenal gland produces, this is probably more than you want to know, but it produces 2 types of androgens. One's called androstenedione and one's called epiandrosterone. Those are 2, you know, not testosterone, but they are androgens, and they're converted to testosterone and another thing called dihydrotestosterone. And right, DHT, which is much more potent than testosterone. In general, like I said, unless you're getting too many side effects from the Lupron and you can't take it, or Firmagon, that's the only indication for an orchiectomy. Otherwise, you're just having unnecessary surgery. Not that it's devastating surgery. I mean, it's not that big a deal, but, you know, you're still going to produce these other androgens, you know, male-like hormones from the adrenal gland, and so it's just not going to help you. The orchiectomy isn't going to help you.
So
how does the Lupron stop the adrenal glands?
Let me just say
It has no effect on the adrenal steroids.
Let me just say a couple of things here. First of all, I don't believe that an orchiectomy is going to deliver any better side effect profile than the Lupron or an LHRH drug. The fact is, in both cases, you don't have testosterone. And without testosterone, that's the reason why you have the side effects. So whether you stop the testosterone chemically or you stop them surgically, you're still going to finish up with the same side effect profile. So when people think they're going to have better side effects by getting castrated, I don't think that's true. Now, there are some, I read recently, because somebody had asked about this, I can't remember where I read it, but there is some evidence that an orchiectomy might be slightly more effective than the Lupron in controlling your testosterone. But the fact is that even when the Lupron is no longer working, in the sense that it isn't controlling your PSA, the reason for that is not because you've got more testosterone in your body. It's because the cancer is becoming more efficient in how it feeds on the testosterone, and it's able to survive on a lot less testosterone. So whether you go through an orchiectomy or you do the chemical, you go through chemical castration, isn't going to make much difference. The PSA is still going to keep going up, because whatever testosterone you do have in your body that's produced by the adrenals, which, as Steve just said, is not controlled by the LHRH drugs, nor is it controlled by the testicles. The cancer is going to find it. This was really what the original impetus. This was the original impetus for developing abiraterone, because abiraterone is able to work at it works at stopping the production or making the production of testosterone from places other than the testicles inefficient. So it addresses I believe what it does is it addresses the process of breaking down testosterone from other sources like cholesterol. Because testosterone is one of the building blocks of cholesterol. And the abiraterone prevents the cancer from breaking down cholesterol. Now, I'm not sure that an orchiectomy is going to make any difference at all. And the reason why men continue to take Lupron once they're castrate resistant, a lot of people say, well, look, if I'm castrate resistant, if the Lupron isn't working, why don't I just stop taking it? Well, the reason you don't stop taking it is because it still keeps the level of testosterone low, and the less testosterone you have in your body, the better you are. So you, right. On the other hand, on the other hand, Paul, you raise a really good point, which is that you should always check your testosterone before you go for another shot, because it's possible that the LHRH drug can stop working. They work in different ways, and some people switch between the drugs, and there's no point in getting another LHRH shot if it's not able to keep your testosterone low. And that, that's a different ball game.
Okay, so I was under a misimpression that Lupron failure meant your testosterone's going up, and so that's what led me to think that an orchiectomy would reverse that. But you're saying Lupron failure means that the cancer is getting more efficient and the PSA is going up.
Correct.
That's what castrate resistance means. Yeah.
Right. That's what castrate resistance.
Yeah, usually when anybody uses the term Lupron failure, they mean that you have become castration resistant, not that the Lupron is no longer controlling the testosterone.
That's right.
Okay.
That's right. It's possible that the situation can occur that you're talking about, where the Lupron just doesn't control the pituitary the way it has done in the past. And then maybe your orchiectomy is an alternative, but I think that's pretty rare.
I think that's really rare, Rick. I think that's extremely rare. And usually what they do in that setting is they just, instead of going to the 3-month, they'll just go to a 1-month injection, just more frequent. The other thing you should check, if your testosterone is going up, you should check your dihydrotestosterone as well, DHT, which is about 10 times more potent, because there are individuals that are able to convert the small amounts of testosterone still there into higher levels of DHT. And there's a woman at University of Texas Southwestern who's done a lot of research on it. And that's something you should definitely check. Most oncologists don't check that.
Right, correct.
And the reason I know that is because I'm in that situation.
I was just going to say, why don't we segue to you, and because that's your situation right now, isn't it?
Yeah, it's unusual, so I don't want to make this into a, like everybody should have it, but I just asked my oncologist to do a DHT, dihydrotestosterone, when I was having the routine blood tests, the whole panel done, and my PSA has been kind of creeping up. And for me, creeping up means it's gone from 8 to 10 to now 12 over a period of about 4 or 5 months. So I did the DHT, and it was 67, which is pretty high. It's not in the normal range, but that's equal to a testosterone of 670, which is a pretty good level of testosterone. So in order to stop that conversion of androstenedione and other adrenal precursors directly to DHT, which Lupron doesn't affect at all, we started Avodart, which you've probably heard about because Snuffy Myers tends to use it all the time on every patient. So I started on Avodart about 3 weeks ago to see, because that blocks the conversion of androstenedione and other adrenal precursors to DHT. So we'll see what happens. That story is still unfolding. But interestingly, I think everybody who has a testosterone done looking for castrate levels should have a DHT periodically as well.
Steve, when have you, did you say you started the Avodart?
Yeah, I started it about 3 weeks ago.
And have you done any measurements since you started?
No. I'm as you know, Rick, I'm going to Hawaii next week, and I decided to just do everything when I get back. So I'll be doing them sometime probably in middle to end of this month.
But you do have a PSA reading. You said your latest one was at 12.
Yeah, right. The latest one was 12, so it is going up for sure. Anyway, but we'll see. This may be just a red herring of the DHT, but the DHT is high, and it's a very potent androgen. So why is it high? And my oncologists, both Andrea and Shreya, Rick, were confused. They didn't know, and then they did some research on Andrea, and there is a woman named I forget her name now, Siriat at University of Texas Southwestern, has written extensively about exactly this. So I pulled up a couple of her articles, and very interesting. She's written a lot about this.
And her recommendation in a situation like that is to use
to go on a 5-alpha hydroxylase inhibitor like Avodart. Yeah. So anyway, so I started the Avodart. It's just another pill. Hey, I take 2 handfuls of pills every day anyway. What's the difference? One more pill ain't gonna hurt me. So I'm on that now for about 3 weeks, and I haven't had any side effects from it. It's supposed to grow your hair. It's our President Trump takes something called Propecia, which is really the same drug, to grow a little more hair in his head.
That's right.
I don't know if it's working or not, but he's on it.
That's right. Does he give you a whiff and straighten your hair and give you a whiff and a perm like he has too, Steve?
I haven't turned orange yet, so that's good.
Okay. Thank God. Okay. All right. Peter, back to you.
Okay, we've gone through the list. How about Tebow? Do you have anything? Because you came in a little bit late after we did a survey of everybody. Do you have anything you want to update us on?
Hey, sorry I lost my connection. Can you hear me?
Yes,
Yes.
we can.
Okay. Actually, I do have an update. I just found out today that even though because none of my relatives are healthy enough or a match to be a donor for this bone marrow transplant clinical trial, they've chosen to allow me to use the bone. So they're simultaneously checking for the best match in the registry, and they're rewriting the clinical trial so that it allows for use of the registry.
Oh, wow.
But it's going to take like 2 months before they choose somebody and we get started. And my back pain's getting worse. Like today, I took more pain pills than ever before, and I still had pain. So I'm kind of worried that before this 2 months is up, I'll be having a hard time. I can't do radium-223 or chemo or anything because that would disqualify me from the transplant trial.
What's the likelihood that they, obviously there's no certainty, but how likely does Sam Denmead think it will be that they'll find a match for you from their database? Hello? Hello?
Tebow, we're not hearing you.
Yeah, I think we lost him. I wasn't sure if it was me that you couldn't hear or Tebow that you couldn't hear. Sorry, we're having such...
It says offline now for some reason.
Okay.
Yeah.
Well, he'll come back.
All right, my Wi-Fi. I'm like right next to my Wi-Fi router, and it keeps dropping out. I don't know why.
I'm having the same problem, Tebow. So don't feel it's just you. I know how you're feeling.
So anyway, yeah, they've definitely gonna have somebody that's a sufficient match. It just takes a while for the process of choosing which one's the best, and plane tickets for that person and getting them here, whatever. So I'm taking.
Person needs to be right there with you when they do the bone marrow transplant. It's not something where they can do it someplace else.
Yeah, they got to have the person co-located for the actual transplant. It's got to go pretty fast from one person to the other. They do a lot of testing before that where we don't have to be together, but then there's one day when we do have to be in the same place.
How far afield do they look for donors?
Well, they have a pretty big registry, and they've already looked and seen that there are multiple people with that are matched well enough to qualify. It doesn't have to be a perfect match for the new way they do these bone marrow transplants.
Okay.
So I told that I was trying to keep working so I can, because the clinical trial requires a performance index score of 0 or 1, which means healthy enough to be working in an office. So I'm going to keep working at least part-time. I'm taking like every other day off because I'm having a lot of fatigue and pain that varies from day to day.
Well, you are pretty amazing, Tebow. I don't know how our thoughts are really with you. You handle this amazingly well. And let's just hope that you find that match that you're looking for, and this does the trick. What can we say? Anybody else have anything they'd like to say to Kiva? Okay.
Okay, thanks.
Thank you. Is there anybody else? I know Larry Fish, I think you had something that you wanted to raise, and was there anybody else that we've missed who wanted to talk tonight?
Correct, this is Jim Cameron.
Oh, Jim Cameron wanted to too. Okay, Larry, go ahead, and then we'll go to Jim.
Hi. Well, just a little change in status. My PSA 5 months ago was 0.1, and then 3 months ago was 0.2, and now it's 0.549. I don't know what the next step is going to be. Are we going to, because of the studies? I mean, I think when I just say we go more commonly go to enzalutamide or to abiraterone. The doctor called and said, make an appointment to see me in a month because I'm busy right now, and stop taking Cataracts. So I saw him when we split, and I'm just going to go see my consultant at Sloan and find a different oncologist for now.
Larry, you've been threatening to do that for a while. I think you just got to do it, man.
I had a fight. We had a fight. We had a fight, a little bit of a fight.
No,
and because NYU does sometimes, she said NYU does do Lupron. I mean, does do Provenge. I didn't know if there was any point in exploring that. And he said, well, you don't do that until you actually have active bone lesions. And I said, I'm trying to prevent the active bone lesions.
Well, that's,
and
he
said, you know, well, if you're not happy with,
that's not true. I mean,
he's always a step behind. Anyway, that's all I wanted to mention.
Okay. So, I mean, the first thing is that you do the Provenge as soon as you're castrate resistant. If you're eligible to do it. It's not when you do it, but the question is, the issue is, when are you eligible to do it? You're eligible to do it when you have 3 successive rises in your...
3
consecutive increases in your PSA, and you're still on an LHRH drug. That's when you're eligible. It's got nothing to do, as far as I know, with metastasis. The only thing is, when you have too much metastasis, we know it's not effective. So your guy is just giving you bad information. How you want to handle that with him or anybody else, I don't know. But I do know he frustrates you. And
we broke up. Richard, we broke up.
Okay.
We broke up like last Wednesday. We broke up.
Last Wednesday.
And I have my appointment at Sloan tomorrow.
Okay.
I'm glad you have enough testosterone to fight. It's good. It's a good sign.
Well,
what's going to happen next?
Well,
what's going to happen next? Most likely, that's the.
I definitely think speaking about Provenge is good. I think that coming off the Cataracts is probably a good possibility because some people get a response out of that.
Is he getting a divorce?
No,
his doctor.
We're getting some feedback from someone. I'm not sure who. Can we tell on the speaker? No. Anyway. Hello.
Yeah, Larry, I'm here.
Oh, okay. I just lost everybody for a second. So you know what I would say to you is talk about Provenge. going off Cataracts is not a bad idea. The only thing is that if you are going to respond to going off Cataracts, you may not get the 3 successive increases that you wanted. You know, see what else they've got over there and what sort of trials they might have that might be interesting.
Yeah, I thought that it was a little premature to talk today because my appointment's tomorrow, but I just let you know what's going to happen, and then I'll tell you what happens after I see the Karen audio at Sloan.
Right. I mean, I don't know that it's premature in the sense that that there are ideas and things to talk about. But one of the things to talk about, for example, is, well, does it make sense for me to go on abiraterone right now on the basis of these tests, these trial results that have just been released? That's a very topical and viable conversation that you can have with her. So, you know, stopping Cataracts is one possibility. Starting abiraterone and prednisone is another possibility. Some docs are offering Xtandi, enzalutamide, at this point, too. I'm not sure we have the clinical basis for it, but there's a good chance that if the abiraterone is going to work, then the Xtandi might work too. So, you know, that's really the skill of the doc, but clearly something is in your future. There needs to be a change in your treatment. Were you diagnosed metastatic, Larry? I can't remember.
Yes, I started with I went because of hip. I had a lot of hip pain.
Well, you know, one other thing to talk to her about, if you haven't had the discussion, it's a subject that is open to discussion at Memorial Sloan Kettering, is does it make any sense to debulk the tumor, the primary, either through surgery or radiation?
Well, it looks like there were a number of tumors at the time. After they looked into it, looked like the lymph node involvement and the right acetabula, the right hip was the primary, but also the left hip and some spinal question.
Right.
That was 2 years ago already. So
right.
The hip pain is not the main problem any longer.
Right.
I think. But doesn't hurt like it used to.
One way that is gaining traction in treating advanced prostate cancer that was never done before is to debulk the tumor. This is something that Steve Bornstein did. I don't know. Steve may have left us. I don't see his picture on there any longer. But and Memorial Sloan Kettering ran a trial 3 or 4 years ago where men with metastatic disease like yourself did surgery. And they published those results earlier this year. I mean, I wasn't that impressed with them, but they basically said that they think that when you debulk the tumor, you get better results. The problem was they were only looking at the end of 24 months or 20 months or something. So I think that, to me, that was a flaw.
My situation was a little more complex because the hip was a, whatever you call it, lesion. It was a hole. It wasn't a growth.
Well, but
it was
unusual. It was metastatic.
There was nothing to take out.
Yeah, but we're not talking about that.
Yes.
We're not talking about removing the lesions in the bone. We're talking about debulking the primary tumor. And the primary tumor is in your prostate. And you've had no direct treatment.
Prostate,
right? And what I'm talking about, and the subject that you should discuss with Dr. Audio is...
Sure, I'll bring that up.
What do you think about debulking the primary, either with radiation or with surgery? I mean, I'm not pushing surgery at all. You know, and probably if it were me, I would want to do it with radiation, but I don't know if it makes sense or it doesn't make sense to debulk the primary. It may make sense. And it's a discussion that you probably couldn't have in a community hospital, but you can have at Memorial Sloan Kettering. If you started talking about debulking the primary with your recent ex, he'd tell you that you're insane. We don't do that, but we do more and more. And
Yeah, that's great to do, actually. I added it to my list to bring up.
Okay. So
I'll bring that up.
I mean, for
definitely
everybody
tomorrow.
who's on the call, it's always good to check in with us before you have an appointment, because there are things that we can raise that might be worth talking about that you haven't thought about. Anybody else have anything that they can suggest for Larry to raise with Dr. Aldio tomorrow?
Well, Rick, this is Len.
Go ahead, Len.
Since Larry he just said he was metastatic, so he'd certainly be eligible for Provenge.
Right.
I don't know why his doctor said he's not.
I know. I agree. Yes, so you've got a few things there to talk about. Provenge, abiraterone, debulking the primary, any trials she may be doing. Try it and tell us how you come out.
Yeah, I'll certainly let everybody know.
Okay. Okay. Jim Cameron.
Yeah, hi, Rick. 3 weeks ago, I finished hyperbaric oxygen treatment. In the last 10 days, I noticed I was having trouble with my vision in both eyes was changing. I told the doctors there that, and they said, "Oh, don't worry about it. You've been doing this for 8 weeks. You got 2 more weeks to go. Your eyes are sometimes the pressure of the oxygen changes the shape of your eyes. Once you stop, they'll come back." So long story short, last week at the 3 weeks, they got worse instead of better. They got so bad that I can't even read the newspaper or hardly use the computer. So I called Dr. Arnott, my surgeon who did the eye surgery last year for the eye cancer. She told me to go to an optometrist down here and said they should be able to tell right away if that's the problem. Well, I did. And my eyes were checked by her going back March 1st of this year. That when I saw her and she said it was okay to get the oxygen treatment. I started the oxygen treatment 5 days later down here in Florida. Well, when they examined my eyes last Thursday, I have large cataracts in both eyes. And I have a couple changes, which I'm really concerned about. In my eye where I had the cancer, a couple changes there.
Right.
Dr. Arnott has talked to the doctor down here and got him to send up all his test results. But like I say, when I was tested 3 months ago, I had just about no cataracts at all. In a matter of 3 months after the oxygen treatment, I virtually can hardly see.
Mm.
So I talked to Dr. Arnott this morning. She's supposed to get back to me. She doesn't want me to get any treatment in Florida. She wants me to come up to Johns Hopkins, which I can't go up there until next Thursday. I get released from the back surgery I had last month, and then my wife and I are going to climb in the car and go up to Johns Hopkins. But it looks like saying that the hyperbaric oxygen caused the cataracts. Because in a matter of 3 months, it just exploded.
Have you spoken to the hyperbaric oxygen folks about side effects?
Yeah, they told me, "Oh, don't worry about it. It'll clear up."
Right, but have you talked about it more recently, since it now seems it's not clearing up?
Well, I talked to him about a week and a half ago, and I told him I was still having trouble, and it didn't seem to be getting any better. Okay, I haven't, since I found out about the cataracts and the other two problems in my eye, I have not, because I've been busy dealing with Johns Hopkins.
Right. I mean, I can only, I can't even begin to imagine how scary this is, Jim. And my thoughts are really with you. I do think that it's probably worth following up with them, not for treatment, but to see if they can give you any guidelines as to prior experience. Because
I'm gonna contact them later on this week. I'm waiting to hear back from Dr. Arnott when she compares all her tests to what the test they took down here. Of course, up at Johns Hopkins, they do more intensive tests than they can do out here in the field in Florida.
Right. And I do think also.
But I'm not going to have anything done until I go back up and see her, because I have a lot of confidence in her.
Yeah, I mean, I do think it makes a lot of sense to try and focus your treatment at Johns Hopkins to the extent you can, and I think that's the right place to be. But it just might be that there's some research that they're aware of, so she probably doesn't have a lot of experience with hyperbaric. I just wonder, with the hyperbaric, to what extent it might affect the pressure in your eye and whether it could cause damage. I don't know.
They say it does affect the pressure in it affects the pressure in my eyes and my ears. My hearing is just starting to come back to normal, and it's 3.5 weeks. It's like getting, sometimes when you get off an airplane and they come down too quick, your ears are popping.
Yeah.
Well, my ears have felt that way for 3 months. Just starting to come back to normal.
Well, I mean, it sounds like you're responding the way that I would respond, which is to get hold of the surgeon at Johns Hopkins. I would be pushing these people a little more. Anybody got any other ideas or anything similar ever happened to anybody else?
Rick, I just a quick search, and it says that hyperbaric oxygen can cause both fluid in the ear and hearing changes. Those are reversible, but also can cause cataracts.
You know that for a fact that they can cause cataracts?
Oh, that's what I read, Jim. I just did a search.
Here's a study. I just put a link in the window to a study from 1984, and they're called nuclear cataracts. And they do happen. They do happen from that. I haven't read the whole study. It's a 6-page article, so I don't know if it's reversible or not. But they are nuclear cataracts, and you might want to do some research on that.
Cataracts are
I'll have to have my wife do it because I'm having a hard time reading the internet.
Right. I can't tell if it's reversible right away. This is also a 1984 study. I would probably want to find something a little.
Yeah, that's 30 years ago.
Right, but they knew about it 30 years ago.
Yeah, and Jim, unfortunately, cataracts are not reversible.
But these are nuclear cataracts.
Well, they told me they can do surgery on the cataracts, the cataract surgery.
Oh, of course. Yeah, they can do surgery, in which case they're removing your lens and they're putting in an artificial
new lenses.
Yeah.
Correct. But especially the eye that I had the melanoma tumor in last year, I'm not going to let anybody do anything in that eye except the surgeon that did the surgery that was pretty much successful.
Yeah, absolutely. I agree with you.
But there is information because when I talked to the doctors over there, I specifically asked them, and my wife was with me, and she doesn't, and they both said, "Oh, whatever happens to your eyes and your ears is minor, and when you're done treatment, it will restore itself to normal."
Maybe that's true for
Well,
most
this study
people.
says the partly... Oh, go
Go
ahead, Rick.
ahead. No, you go ahead, Christine. That's fine.
Oh, it just says in the study, it says the partly reversible nuclear cataract was observed in 2 of the patients, has not been reported previously. So far, nuclear cataract in humans has been considered to be irreversible, but apparently the lens can sometimes recover from an acute toxic event of this kind.
No.
So I can send you the link to the study if you want.
Okay, my email is Jim Venice,
Okay.
VENICE @Comcast.net.
VENIC?
ICE.
Okay, so I have JIMBENICE
@Comcast.net.
Okay, I will send that to you from Christine Sibley, okay, at hotmail.com.
Okay, I'll look forward to receiving it. Thank you for your help.
Okay, no problem.
Thanks a lot, Christine. I just had pulled up this study and I was going to do it, but if you can do it tonight, that'd be great. When we finish, I'm going to hit this. I have to be up.
I know, you poor thing, you have a meeting tomorrow too.
Not only that, I've got to.
Hey, Rick, you have a safe.
Thanks. I've got to even check if I can get to the meeting, because the meeting is only a few hundred yards from where the terror attack was on Saturday night. I've got to go to London Bridge Station.
Oh boy.
So, and I think London Bridge Station is open because their offices are right in that area. So, but Jim, what I wanted to say to you is that these people must be aware of this. What they're telling you is this is what happens to most people. I think you need to call them and you need to say, look, I'm not most people. We know this happens. Here's evidence from back in 1984, which is when this study was published. There may be more recent studies. And, maybe...
Yeah, man, like I said, well, I talked to them last week, and they just kind of, oh, don't worry about it. I talked to the nurses over there, and they said, oh, don't worry about it. It'll restore. They just, I got the impression they just wanted to get me off the phone. But if I have to, the place is right around the corner from my house. I'll drive over there to see the doctor.
Right. Again, it's not the nurses. The nurses probably don't even know. I mean, you've got to sit down with the doctor. You put this study in front of him, which says nuclear cataract and myopia during hyperbaric oxygen therapy. Hopefully, you'll be able to do a little more research and find something more recent on this. But it is a known side effect, and thanks to Len and Christine for finding these references. And all too often,
yes, that'll help you a great deal.
They don't look. They slough you off with these medical professionals, and that's why we run these groups, because through telling us about it, we're leading you in the right direction, and hopefully now they'll listen to you a little more. You don't maybe want them to treat it, but at least you can talk to your doc in Johns Hopkins in a more sensible fashion. Right?
Yeah. Well, I expect to hear from her tomorrow, so I'm sure she'll have a lot more. If she got all the reports today, I'm sure she'll have a lot more information for me tomorrow.
Okay.
Jim, I had a question about your email. It bounced back.
Okay. It's Jim, J-I-M, Venice, V-E-N-I-C-E.
Oh, got it. I spelled it Venice. Okay. There we go. I'll get it to you now.
Okay, thank you.
You're welcome.
Thanks, Christine. All right. Anyone else? If not, I'm going to close out. Yes.
Just me. Then.
Oh, hello, Ken. Well, did you just come on?
Yeah, a little while ago. I've been listening.
Okay. Yeah, go ahead.
No, but I got. Did you guys, or did you give any more thought to questions that I might ask this doctor at MD Anderson next week in regards to debunking the primary? You know, I'm going to meet with him on Monday.
Right. Well, I mean, I think the question again is, you know, what does he think it's of value? I mean, it is something that they're doing. You heard the discussion with Larry Fish, yes? Did you hear our discussion with Larry Fish just a few minutes ago?
I did.
Yep. So you know, they are doing it. They're doing it at Memorial Sloan Kettering. It's something that it has been done in trial in other places with radiation. And Steve persuaded Kaiser to do it for him. I think it's worth raising. I don't have anything more than that, than to discuss with them whether it's an alternative. You know, my feeling in your case is that it might be a little premature to raise it. I know that Steve certainly didn't until he was finished with his chemotherapy, at which point he'd seen some other issues. He'd seen some results, rather. I can't remember if he did Provenge or he did the radiation first. I think he did the radiation first. But yeah, I mean, there are a bunch of things always to discuss. The Provenge, the same things we just talked about. These new studies that seem to suggest very early introduction of abiraterone or early introduction of enzalutamide. These are all very worthwhile discussions to have with your doc.
I just looked up your cataract, and that says...
Jim Cameron, could you mute for us, please? Can you mute for us, Jim? Thanks. Sorry, Ken. Do you want to respond?
No, it's okay. What I'll do is I'll just go and listen. You know, I don't have a lot of questions for the guy, so, you know, he's no doubt going to give a pitch in regards to why he feels like, you know, removing the primary has valid validity or whatever. So I'm going to listen to his comments. That's what Paul Korn, I think, under the impression, because MD Anderson is doing this clinical trial in regards to people like me that have had that haven't had their prostate because of their Gleason, and they've already gone through chemo, and I think the trial started a year ago, and I don't know if it's like Korn is pushing it a little bit. But I'm going to ask him just straight out if there's just any facts. Does he know of any facts why he's recommending it, or can he not tell when the clinical trial is still underway?
Right. Well, you know, he may refer you to the Memorial Sloan Kettering trial, but I'm afraid tonight I really do have to stop because it's already it's 3 o'clock, 3 a.m. in the morning here. So I've got to close out. Otherwise, I'd be more than happy to spend some more time with you. But let's try and talk.
Good night, Rick.
Good night.
It's all right. It's all right.
Okay. Good night, everybody.
Good night, guys. Good night.